Great. Hi, everyone. I'm Andrea, and I'm the morphology lead scientist, and I'm going to be talking about the performance scoring that has recently been introduced to our blood film program. The blood film program was established in 1978 and has predominantly remained the same since then. 16 blood films are distributed each year, 2 glass slides across 8 surveys. Participants view the film and decide their 5 most significant morphological features and attempt a morphology comment or a suggested diagnosis. Currently, we have 571 participating laboratories in the UK and worldwide. It is quite simple to perform and score our other programs, such as the full blood count, reticulocytes, infectious mononucleosis programs, as they have a specific value, or they are positive or negative. And we know that what we have provided you with, and if your analyzer is far off the mark of that target, then it's very clear. But morphology is more subjective. We all see things differently. We have our own limits in our mind, but when something when something is microcytic or not, or hyperchromic or not, therefore, there has been a lot of discussion required for introducing performance assessment for morphology. Up until recently, there has only been a penalty for non-participation, rendering the scheme essentially educational only for participants. It was a recent visit by UCAS to UK NEQAS Haematology Watford under ISO 17043 that prompted the review of the morphology schemes and whether we could include some level of performance assessment. Importantly, it would also bring the morphology scheme in line with the other UK NEQAS Haematology EQA schemes. It also falls under the requirements of ISO 15189 for medical laboratories. After the UCAS visit, we discussed the issue of performance assessment with our morphology experts and scientific advisory panel and came up with a number of scoring systems and trialed them. We have been shadow scoring surveys since 2017 to ensure that the system was working correctly and to iron out any glitches and kinks in the system. The scoring system was formally introduced to participants in November 2022 with 2022-07BF. Feedback from participants so far has been good. We just get occasional queries as to how to understand the scoring system, which is one of the reasons that we are having this webinar. An explanation of the experts' flag selection will be included from 2405BF. The best scoring system of the few that we trialed was a model that uses 2 indicators: consensus score, which is a performance score based on a statistical analysis of comments returned, and expert flags, which is a performance score using significant, critical, or important comments that are selected by an expert panel. I'll expand on this in the next couple of slides. For the consensus score, we collect the numbers of comment codes for a case. You'll be familiar with the histogram on the right, as it has been included in morphology reports for as long as I can remember. We rank them from 1 to 10 in order of most selected to least selected. There'll be those further down than 10, but they're less likely to have enough comments to receive a point score. The ranked comments are derived percentage points, which then become the physical score. So the 5 reported comments by a participant, as you can see in the box on your left, will have their score summed, which is demonstrated in the red circle on the top right. For the example on the left of the page, the top right scoring information is listed. So the target value for this case was 63, and the top right lab did very well by scoring 74, and the highest possible score for this survey was 76. The target value is the median score of all the participant laboratories and is demonstrated on the graph by the red line. This participant score was 74, as I said, which is excellent. The highest possible score was 76. The bottom right scoring information is to demonstrate a laboratory that scored less than 63, which resulted in a deviation index, or DI, of 0.6. A result greater than or equal to the target value will receive a DI of 0. A DI below the target value will receive a DI score based on their distance from the target value. The deviation index, or DI, for a participant score can be derived using the same formula as for the existing schemes. Deviation index equals the laboratory score minus the consensus target median score over the estimated standard deviation, where the estimated standard deviation equals the interquartile range over 1.349. The DI is always recorded as a positive value. Like I said on the previous slide, for scores greater than or equal to the median or target, the DI is 0. So this is 2404 BF1, which you might recognize. which is the case I've been using as an example for some of these performance scores. So if we all just take a closer look together, I was wondering if you could tell me some of the things that you're seeing on this film. There's a couple of things that we can comment on that we can see in this field. So if you'd like to put in what you can see in the chat function, and then we can talk about it. There's something in the chat function, but I think, great, polychromasia, thank you. Yes, agreed. And I think there's some, now I've gone past them, but I'd say, I don't know if you can see my cursor, but that's a nice target cell. This is a polychromatic target cell. I mean, teardrop cell. I'm saying that because I'm looking at this target cell on the right here, sorry. Right, let's have a look around at some of the white cells. Yes, thrombocytopenia, Hal Jolly bodies, agreed. That looks like a little irregularly contracted cell, maybe a little fragment, definitely Hal Jolly bodies. And this is one of the very interesting features of 2404BF1. It's a plasma cell, but these are actually called MOT cells. So they have these cytoplasmic inclusions. There we go, MOT cells. Thank you for that in the chat. Oops, a little bit too far in. Let's keep having a look around. That looks like a very irregularly contracted cell there. Wouldn't call it a spherocyte because it's not perfectly round. Rouleau, yes, thank you for that. Definitely some rouleau. That looks like the remains of a nucleated red there, but it's just missing some of its cytoplasm. As you can see, there's so many comments that you can say for every single for this film. It's difficult to decide on the top 5. So we do appreciate the complexity of that. Let's see. It's a bit of a more normal mature lymphocyte. There was some, oh wow, what an example of a MOT cell. I mean, and really classic rouleau here. Yeah, this was just such a beautiful film to be able to send out to everybody. Really such a treat. Right, lots of rouleau, some target cells, MOT cells. I was hoping to find you a nice normal plasma cell. There we go. Here's a nice plasma cell, looks like a fried egg. The nucleus is, to the one side, very blue staining cytoplasm. And here's a left shifted neutrophil. It's got more of the sort of sausage shape to the nucleus. So yeah. I wanted to do, there's a nice monocyte. Nice lacy cytoplasm. There's granules visible, quite a large cell. Yes. So this was a plasma cell leukemia, I think. I wanted to read an excerpt from the experts' commentary, but I can't seem to have both on my, there's some debris. I can't seem to have both on my screen at the same time. So I will come back to reading what the experts had to say in their report of this one. But yeah, it's just really great to be able to look at a film like this and discuss it together. Yeah, and well done, everyone. Everyone for putting in all their great comments. Okay, I'm going to see if I can get back my word so I can find out where the oh yes, so to quote from the expert's commentary from the report, this is a really remarkable film. There were clearly plasma cells and plasmacytoid lymphocytes, and the increased rouleau formation suggested the possibility of a paraprotein and a diagnosis of a plasma cell neoplasm, designated multiple myeloma or plasma cell myeloma, depending on whether you are following the international consensus classification of hemopoietic neoplasms or the 2022 WHO classification. The neoplastic cells are sufficiently numerous for a diagnosis of plasma cell leukemia. There was also an increase of what appeared to be large granular lymphocytes. Possibly these were reactive to the myeloma. What was extraordinary was the presence of cells the MOT cells, sometimes these occurred in clusters. At a lower power, they raise the possibility of a circulating adenocarcinoma cells. However, a high power examination, as shown here, sorry, that's referring to an image in the report, suggests that they are also a neoplastic plasma cell. Cytoplasm is very basophilic. There's a Golgi zone visible on the right side of the nucleus in this image, and there's something precipitated within the vacuoles, presumably the paraprotein. Yes, with thanks to Barbara Bain for that excellent commentary. So I'm going to move on to the next slide. Right, performance monitoring can be achieved using the same procedure as the other hematology EQA schemes that you will all probably be very familiar with. The current DIs from the two films are combined and added to the previous two surveys and multiplied by a factor to give a running total for each participant. DI values greater than 3.5 are capped at 3.5 and multiplied by 6. So a performance score of 0.6, 0, 0, 0.5, 0.3, 0.6 times 6 would give you a performance score of 17, which is what I'm demonstrating here, which is very satisfactory performance. But as I've already mentioned, morphology is quite subjective, so don't be disheartened by the performance score. In fact, your laboratory with a lower score may have actually seen the more important or significant features than the one that was ranked more highly by the vast majority of participants. This is where the expert morphology flags come in. Expert flags are used to protect against an important comment being missed by the majority in the consensus score, to help with interpretation of the scores, and in order to add further value to the educational component of the scheme. An expert flag or two are assigned during the reporting phase of the analysis. So 2402 BF1 was a plasma cell. Oh, it was 2402. I said 2404. Apologies. That was incorrect. 2402 BF1 was the film we just looked at, was a plasma cell myeloma with some beautiful MOT cells. The expert selected plasma cells as a critical comment and rouleau as an important comment. A critical comment is given I'm at a loss for words. The critical comment is given the designation of a capital A, and an important comment is given the designation of a lowercase a. Those are indicated in the circles on the right. So the lab in the top right, they successfully included both of the expert flags as part of their top 5 comments. So they receive a capital A, lowercase a, whereas the lab at the bottom, they didn't mention plasma cells, but they did mention rouleau. So they receive an X to say that they missed that expert comment, and they receive the lowercase a because they did successfully note that comment. So an interesting issue that we came across was with the normal film that was sent out for 2402 BF2, was that the only morphology comment was normal film, which left us with a conundrum with how to capture this on the report, as we did not want anyone who had put in the correct comment to receive an X to say that the expert comment was not noted. Therefore, we captured normal film as both the capital A and the lowercase a. But this case also highlights that these films do complicate the consensus score, as this laboratory got it 100% correct. But because of all the other labs putting in multiple different coded comments, they've ended up with a result slightly less than the target value, which gives them a small DI. This demonstrates the value of the coded comments and the possible bias that can occur with the consensus scoring. This is why it is important to use both systems to be for a fair, accurate, and educational scoring. You can also see how much lower the target value is for this case, with a maximum possible score of 50, but that wouldn't have been a particularly accurate report if you had said all of those things. Right, and so now we can take a little look at let's have a look at the normal film. It's really, really difficult for us to get a good normal film, because we're getting this as excess from laboratories when they're done with the material, and so somebody attending hospital, kind of no matter what they're attending for, may not have 100% normal blood. So we do sometimes see little things, and also I understand that, you know, when participants, as previously being a participant myself, when participants receive, I've lost the chat box, so I don't know if anyone is saying anything. There it is. Yes. Mark Lewis. Definitely much harder to examine a normal film. You get far less clinical information than you would normally have in the lab. We do this to keep it consistent and to not obviously give away what the answer is. So under normal circumstances in your own lab, you wouldn't be up against the complexity of not having anything aside from the white cell count and the hemoglobin. I mean, you can see that the platelet count is nice and normal, which is always a good place to start. This looks like a fairly nice normal lymphocyte. A good way of assessing whether the red cells are microcytic or macrocytic is to compare them to a nice normal lymphocyte's nucleus. So if you compare this one to the other ones, they're almost the same size. So I think we're okay in saying that this is a fairly normocytic size, although like somebody said in the comments in the chat, there is some anisocytosis, and yes, it's just basically nobody is as normal as we think they are, is what I'm trying to say. And also, we appreciate how difficult it is for you with the very limited clinical information that you receive. And so when you receive these, you think that we're trying to fool you. Here's a nice bar body. In the neutrophil. So that little drumstick sticking out there, it's just some excess chromosomes material that women have. And so when you see that, you can be fairly confident that you are looking at a woman's film rather than a man's. So you can also catch us out with that. I mean, we always send you a truthful slide. But if we said it was a man and it has a bar body, then you can probably check with us. Another really great normal lymphocyte. I would definitely use this size, this look, as a way of assessing the red cells around it, on whether they are microcytic or macrocytic. But to me, it looks fairly normochromic. What else can we say? The neutrophils are looking quite nice. There's some granulation, as there should be, and there's all the lobes of the nucleus as we're expecting. What else can we see? See, there's a bit of a pencil cell to confuse you. That one looks a little bit like a stomatocyte. I'm not sure if you can actually see my cursor when I'm drawing on things. I'm hoping you can. Oh, great. Thank you for confirming that for me. Yes, so here's a platelet. I saw in the chat somebody said that there was a hypergranular platelet, and that definitely looks quite hypergranular, quite gray, doesn't have the purple granules that we see over here, but they're a fairly nice normal size. But let's see if we can. Here's a bit of a larger one. Let me pull that over. Slightly larger one. If a platelet is larger than the red cells, then we would say it's a giant platelet. And if it is sort of larger than half the size of a red cell, then I would say we would call it a large platelet. But yes, there are definitely some funny looking cells in here. Even though this is apparently a completely normal lady that we got blood from. So yes, I mean, starts of a target cell there. And what else can we see? So we do really understand how hard these films are to receive with very little clinical information. But I thought it would be really fun to look at it together. Wow, that's a really beautiful looking monocyte. Gosh, looks a bit like butterfly wings. Right. Oh, there looks like a nice target cell. So this one almost looks a little bit like a mushroom. So yeah, red cell morphology, there is so much that you can see, but a lot of it is actually, we only saw sort of one target cell there, and we saw just the one mushroom cell. You want to see sort of quite a few more. Oh, I always spot these things. You can see the hemoglobin's pulling to one side here. Some people like to call these slipper cells. But yeah, but I'm only seeing one, and some of them can happen from spreading as well. So you'd want to see a couple in each field before you start thinking, oh, oh, there's target cells everywhere. Whereas we're definitely not seeing that. Yes, another nice monocyte. Great. So I think that is probably I think there were just one or two more things I wanted to say from the experts' report on this. I'm just going to close that and bring the experts' comment back up. To quote from Barbara Bain again, this case was included as a normal film, and 36% of participants reported it as such. It's always difficult to know how to interpret minor abnormalities in a nearly normal blood form, particularly in the absence of clinical information. When I reviewed, as in when Barbara reviewed the film, without other information, she recorded it as almost normal, but thought there were enough atypical or immature lymphocytes to be worth a comment. So, I mean, I think that just tells you just how hard it is. And I really wanted to include this one just to show how much we all find it difficult when we don't have all the clinical information, the whole full blood count, why the patient presented at the hospital or the emergency room. Yeah. So thank you for participating in that with me. Let me move on to the next film. So here I did a comparison of the cumulative consensus scores against the expert flags. Oh, sorry, I don't know why I ended up with putting in all laboratories twice. Apologies for that error. Right, so I was comparing the cumulative consensus score against the accumulated number of expert flags over the last 3 surveys. And as you can see that for the most part, the more flags that labs are accurately reporting to the experts, I mean, in matching up with the experts, the lower their cumulative scores tend to be, and these very high ones are probably from some non-participation scores, for missing a survey. Right, so I wanted to point out this little group. There are 46 laboratories that receive the maximum of 11 flags, with an average consensus score of 6.6, a minimum of 0.5, which is insanely good, and a maximum of 20.3. But I mean, there's so many labs that are doing really, really well and have, and I mean, it's really wonderful to see that this performance scoring is really demonstrating just how well our labs are doing in their morphology, and their ability to detect conditions and the various morphological features, and attempt a diagnosis. So I really do want to commend everyone. Yes, okay. And that is all I had. So are there any questions, since we actually have a lot more time for questions than I expected? I think I spoke too quickly. Apologies for that. Any questions?
Well, thank you. Thank you very much, Andrea. I think it's very useful. And obviously, the text of this webinar or this recording will actually be available to participants, so they will be able to go through and look at it and go over any of the details again. Because I'm aware that we have had there have been a number. There are questions about the scoring system. In general, it has been fairly well received, and we haven't had a lot of adverse feedback. But there are questions in particular about the use of the expert flags and why they were chosen. And is there any update on what we might do about giving more information on that? Andrea, sorry.
Sorry, I was reading something in the chat and missed that. I'm so sorry. Would you mind repeating the question?
I was just going to say, obviously one of the questions is we more frequently get asked is, why were these particular expert flags selected? And there have been some and there has been some interesting feedback, and I wonder what we plan to do to address that.
Yes, so that is a very common question that we get. We have been in discussion with our experts, and they now we've been working on having them, when they provide us with their specific expert comments that they're selecting, and the designation they're giving it, whether it is the capital A or the lowercase a, Oh, and something else I wanted to say on that, they could decide to do two capital A's or two lowercase a's. It doesn't have to be a case of it must be one capital A and one lowercase a. We do leave it up to the experts how they would like to do that. But to go back to the reasons for their selection, we have now captured that, and we will be including that in the reports from 2405 BF. So the very next case will have that for the first time, and it's going to have a table that hopefully very clearly explains exactly why the expert selected their flag. Some of our experts do address it a little bit in their written commentary, but just for the sake of complete consistency, because it is something that they are providing us with, we are going to provide that to you in your reports from 2405 BF. So please give us feedback once you do see those new reports. If that is how you would like to see it, or if you have any advice or guidance on how perhaps we could do the report better, to make it clearer. So yeah, that's what we're going to introduce.
Yeah, no, I think that's useful. Thank you. So see, there's a question from Natalie Peck. She's actually asked it of everybody about how people use the scores to monitor performance. At what point do you record an out with performance or out with consensus and take further actions? Obviously, we as UK NEQAS don't know, but have you got any thoughts, Andrea, on how people could use these to monitor their performance on a month by month basis? I won't say day to day, because obviously we don't send slides out every day. We send eight sets out a year. But sort of as the surveys come out, how could laboratories use these scores as part of their evaluation of performance?
So I think it's really good if you review your report when it comes back and have a look at your score. But like I did say earlier, and I don't get too hung up if you are slightly below the target, because if you have rather listed the expert flags, and those happen to have very low scores. Like we had a case where the expert listed Dolly bodies as one of the expert flags, and I think a handful of labs had recorded that. So you need to look at them together. So if your score is below the target, but you've seen the expert flags, I would write it up like that and be like, yes, we are slightly below the target, but we are satisfied with our lab's performance because we saw the expert flags that a lot of other people didn't. Or if you didn't see the expert flags, but you got a really good score, you could write it up and say, we've got a really good consensus score, but we missed this expert flag. So as a team, we're going to go back and have a look at this film and just go back and try and have a look and see if we can find that thing that the experts commented on that we missed. So I would always just keep it honest. You've maybe missed something, maybe go back and review, but sometimes being below the target, is not necessarily a bad thing, and you can write that up. Yeah, so I think just write it up in your quality management system that you have reviewed your EQA, and just have a look at your score, have a look at the report that's been written, and see how you're doing in comparison to that report and the score and the expert flags. And I think that will give you a real global picture of how your lab is really doing and performing. Yeah, but as a whole, labs do seem to perform really quite well consistently, which is something we're very proud of. So well done.
And I mean, that leads us on to another question, which has come from Stephen Leather, who has asked, what would you NEQAS suggest as a measure of acceptable performance? DI, for example, of less than 2, one or both comments, or a combination of both. And that, I mean, if you don't mind, Andrea, I'll happily take that one. It is very difficult, Stephen. It's to know what we would say to people, because as has also been reflected in the chat, another participant has said, we don't, why, how do we measure performance when what we're giving people is not so much a measure of what their normal working will be, i.e. they don't have all the full blood count, etc., etc. I think one thing I would say about overall performance, and which I think is going to be the next phase of developing the performance assessment here, is to provide laboratories with an annual summary of how they've performed. And I think that is going to be more valuable than anything, just simply because I certainly am not, as director, I'm not going to write to any laboratory saying, oh dear, you know, you missed the target cells in this slide or something like that, because, you know, basically, I don't think we need to have those conversations. There's also the issue that we may send out a slide which is of great interest and great educational interest, but maybe not something that you see on a regular basis. For example, we might send a, you know, in actual fact, we won't send pediatric cases because it's so difficult to get the number of glass slides that we need. However, we might send, you know, something that is perhaps very much an adult case and it goes to a pediatric hospital. They may not see those cases on a day-to-day basis, but we would like people to participate. We may also send some very esoteric and very difficult and unusual cases because people want to see those, but again, they're not what your normal lab scientists are seeing every day. And I think, therefore, it will be very useful for us to provide, and this will be the next phase, what I will call an annual summary, which would have a list of all the cases that have been sent out, probably what they contained, an overall summary of the general participants' performance and how you performed. But I think also that in that there needs to be some reflection of the degree of difficulty or the degree of interest in the case, because clearly this is not something that can be measured in the same way as we can measure the performance of an analyzer. So this is all here as guidance. We don't give any we don't actually give any direction as to how participants should look at the slides, whether you look at them individually, whether you look at them as a group and then put in a consensus value, you know, how you look at them afterwards. Because I think the most important thing is that we keep the educational aspect of this slide and this program going. Now, there's a couple of other things that have popped in that have been quite interesting. There's the issue about why do we not get more patients' results, indices, etc., and clinical info. The reason for that is certainly at the time of giving this webinar, and everything can change, obviously. The purpose of this program is a morphology skills program rather than a case interpretation program. And the morphology skills are, how good is your morphology? And I know certainly some years ago, UK NEQAS sent out slides in consecutive, or we sent out the same slides. We sent them with different information. And for example, in one we gave the platelet counts. It had very high platelets, and another, I think we gave an MCV, which we didn't the first time we sent it out. And it actually swayed the comments that people sent back to us. If we told people that the platelet count was 450, we got far more comments back that there was thrombocytosis present. If we told people that the MCV was 105, we got far more comments back saying this shows macrocytosis. And there is this difference then, therefore, of differentiating what you're doing about the case interpretation and what you're doing about the morphology skills. And there's always a debate as to what is the best. We may be developing more online programs that allow you to do more of the morphology skills. And Christine, sorry, that largely came in answer to yourself, Christina Teuchert, and you've actually came back and said, when you say it like that, it does make sense. And there is this debate over what is the best thing. The next thing I was just going to say, Mark Lewis has come and asked a question about including the smear cells actually in the differential or not. And that has cropped up in a couple of places, Andrea. I don't know what the general view is or whether you'd like to give any opinion on how smear cells should be counted and the significance of them.
Yes, our general advice is to count the smear cells with the cell that they are identified as. So you count the smear cells with the lymphocytes, you know, or depending on what cell type it is. Just because it's usually because they are significantly more friable due to the condition that they have, the condition the person has. So, you know, if they were counted through an analyzer, they would count as lymphocytes, but because we're spreading it, and those cells are just that much more delicate and friable, then they end up being smear cells on the film, and that's why the general advice is to count the smear cells with the lymphocytes together. You could make a comment, you count them together, and you could make a comment in the DF comment box to be like, 15% of the were lymphocytes and 15, 85% were smear cells, if you do want to separate it out somewhere. But yes, we do advise that you count them together.
Yeah, and I think certainly discussions that came out of a recent UK NEQAS Morphology Scientific Advisory Group was that we were going to pick up with one of the major suppliers of automated cell counting analyzers in terms of morphology counting, that we were going to pick up with them, because I believe that in their differentials they do actually show that they count the smear cells as kind of per 100 white cells, and there was an opinion from our scientific advisory group that we should pick that up with them, that advice, because I do understand that the standard advice is to count them with the cell type that you believe they come from, although that will probably always be a degree of debate. Natalie has also asked, do you monitor lab performance scores for the blood form morphology and contact them if they've got a consistently high score, as with the other schemes? To be quite honest, Natalie, as director, I probably will not, because it would open so much of a debate, and I do not think this is something that is. I think it is so subjective. It would be difficult to pick it up on an individual case-by-case basis. Once we start to institute some sort of annual reporting, I think then that should be fed back to the laboratory for them to consider how they're performing. If a laboratory performed very badly over an entire year, I might take advice from our scientific advisors as to whether we should pick that up with them. But I think the purpose of this programme is that it must remain educational more than anything, because I think that is its greatest impact. We've also got other comments. We've got one comment from an anonymous attendee that says, do the experts ever have different or clashing opinion on what comments or flags can be used? I don't know, Andrea, whether you wanted to explain a little how we actually get the expert comments and the expert flags. Because I'm thinking back to the usual terminology that if you put 6 haematologists in a room, you'll come out with 6 different opinions. But that's perhaps being a little unfair to our colleagues.
Yes. So every case, every survey that gets sent out, you receive 2 slides. So, for example, 2404 BF1 and 2404 BF2, and that pair is assigned to an expert. We have 4 experts who very kindly write reports for us and advise us, and they're also part of our morphology scientific advisory group. And so they each take a turn twice a year, because we send out 8. So twice a year, they each do a pair. And they will decide on their expert flags and their report by themselves. We have occasionally sort of I've lost a word, tried to cast the net a little wider, and we've asked the other experts for their opinion on a flag. But that usually comes from the expert themselves, where they actually ask their other experts for their input. And they are usually fairly similar with their critical type of comments, but I would say they have their own biases when it comes to the important comments. I don't know if that is an unfair thing to say, but I think we all have our own different limits and settings and things in our own mind when it comes to morphology, based on the things we've seen already, and our experts who are exceptionally expert in the field, they have that too. So I do find that their critical comments tend to be very spot on, and their important comments do vary slightly more. But I think because we have 4 experts that are on twice a year, that is spread throughout the year, and so you will get. I feel like that will minimize the bias over time.
Yeah, I mean, it's difficult, and obviously these schemes they've taken a long time to develop, and will remain in development as well. It will, as with all our programs and all our scoring, and our process for accumulating slides is that we receive cases from participants, from experts, from a variety of places. Throughout the year, these cases are made as and when they arrive. We don't screen them beforehand, just simply because we just have to get the slides made and stained because of the fragility of the cells. We then hold a meeting with our expert panel and members of our Morphology Scientific Advisory Group, where we all sit round a multi-head microscope and screen the slides for their quality, their interest, and general appearance, and whether what we got out of them, and also against what other information we have from the case that could be used to construct the expert report. The cases are then, the program is then made up from those cases, and as you will note that there are many that they're often paired or they may be contrasting. There's some thought goes into how the program is constructed. Now we will consider developing whether we need to continue to look at whether we need more of a consensus between the experts on our on the actual expert flagging and what is important. These are all items that carry on. So any feedback anybody has to us on how this is done and what should be done, I think is very useful, because this will keep feeding back into the scientific advisors who are helping us construct the cases. And I see there's a there's a question, actually, an appropriate question from Umbri Mazar, who said, how do you select the cases to send? Well, that is how it is selected, Umbri. We try to construct them so that we're not sending out all the same throughout the year, and they are selected by our expert panel as to what we feel would be an interesting and educational program for the participants. However, it does depend on what we receive throughout the year and how we manage to accumulate cases. We receive and make far more slides than we actually use. We send 16 cases a year. We generally will receive far more than that and make far more than that, so that we've always got a library that we can keep constructing. But any feedback on what people would like to see in the program would always be very useful, and we would try and search out those cases. Christina's also asked, is there any difference in manually made slides versus automated? We make all of our slides manually, Christina, just simply because we can't get 600 to 800 slides out of one single EDTA using any of the automated slide making devices. We have tried, but they take too much blood. So we deal with it manually. What we're also looking at, however, and we've been working with the providers of what I would call the automated cell identification systems, without using any commercial manufacturers' names, we have been working with them to try to see how useful or how acceptable our slides are to those instruments or to those devices. And Andrea, I don't know if you just wanted to say about submitting data from automated cell identification systems as part of the blood film morphology, and especially the manual differential at the moment program.
Yes. So for the manual differential program that goes out in tandem with the blood films 4 times a year, we have a pilot scheme where you can run the film through your automated cell identification system, and you can report that that data next to your manual differential, and we will analyze all of those results, and you can get a report that shows what everybody else's automated cell identification systems are getting approximately. We also, in that data, we allow you to submit the unverified data, so the sort of raw data from the analyzer of what it has counted, and then there's also an area for the verified data once a BMS has taken a look at it and made any adjustments that they feel are necessary. So we have, we feel we've covered all aspects of it for now. But if you'd like, if your lab is not currently signed up for that pilot or newly has an automated cell imaging system, please get in touch and we'll get you added to that. It's quite a small program still. I think we have about 50 or 55 labs currently signed up. But the more we can have, the better. And also, we've asked that if you do run your slide through the automated cell imaging system and you use it to report your morphology comments, to add that in the comment box, because we're just trying to collect data on actually how accurate these automated cell imaging systems are for the comment codes as well. So yeah, thank you.
We've got also another question from an anonymous attendee who said, should the diagnosis be made by consultant haematologist? And what if this is in conflict with the BMS comments for the slide being reviewed, which is an interesting case. I know that certainly there are members of our scientific advisory group that say that the slide should go through the same process as you would do in your laboratory. So it should be, you know, screened out really at the level that would be appropriate within your laboratory. I'm not sure that I'm as fixed as that, because I think that the most important thing is that you as a laboratory or a group of anybody, group of participants actually gets the most out of the slide that you can. And I do know, because sometimes I've had to write to participants, generally more about parasite slides, where I've written to a laboratory and said, you know, this had a P. falciparum in it, you called it, you know, P. vivax or something like that. And I quite frequently get quite ironic comments back from whoever I've written to, might be the lab manager, saying, well, you know, how we do it in our lab is that all 6 people look at it and we then all decide, and basically the majority opinion at the end of our decision-making process is the one that's reported. But I said it was a P. falciparum, but everybody outvoted me. You know, so we do get those kind of comments back. I also get comments back from the laboratories that said, we thought this, for example, was a P. falciparum, but our consultant haematologist disagreed with us and we had to put his or her comments in. So I think the important thing is that we learn from this, and everything has to be a learning process. And I very much would like to encourage laboratories to look at the reports and the slides again when the reports are sent out. I'm also wondering, given the interest that there has been from using those scan slides today, Andrea, as to whether there is something that we as a group, you know, UK NEQAS could consider. And I might also ask people here to put a quick, you know, thumbs up in the chat or something like that, as to whether it would be useful to have occasional webinars where we can go over cases, you know, slides that we have sent out. We can then scan them and then go back over and look at some of the items that were actually you know, as an educational exercise, that were featured or not featured or missed, or what the general feedback was. So it would be useful to know whether participants will find that useful, and we could try and build that in, resources permitting, we could try and build that into our programs, as it were, and our webinar programs. Using these scan slides here today has been a first. You know, it's been a bit of an experiment, and Andrea was really nervous this morning as to whether it was going to work and how it was going to work. But
absolutely,
you know, it would be useful. So if people do think that would be useful, then I'm sure it's something that we could try and build in on occasion, and have some occasional. I've got lots of beneficials, great ideas, thumbs up, you know, etc. And I think people might find that quite useful. So we perhaps should think about that for the future. Then another item. I'm sorry, I'm aware of time. We've got a couple of minutes left. Another anonymous attendee has said, within our internal reporting, we've been marked down as not having made the correct diagnosis on a NEQAS film, despite having the correct morphological comments. We don't have haematologists on site. So it is only the BMS who come to a consensus on a diagnosis. And obviously for patients' films, especially complex and difficult patients' films, such as we send out, they would refer off-site to a consultant if it was needed. They personally felt it was unfair, but just interested on views. I don't know, Andrea, whether you've got, was as a final question, whether you've got any views on that? I can envisage the difficulty of, having a
Yeah.
group of BMSs that would normally refer a slide off-site. I know that there are members of our scientific advisory group that say that slide should be referred off-site to the consultant for the final comment. I am also aware that there's only a week or 10 days turnaround on the slides. Consultants are busy and people may not get their reports back in time. So there is a compromise there. I don't know if you've got any views on that.
Yeah, I think I can understand the sort of sting that you feel, and I'm really glad that you attempted a diagnosis, because I think that's so important for us to learn. Um, Especially when we commit to a diagnosis like that. Even if you're actually committing to a couple, that's also fine. But I think in this case, I would probably write it up that it is an unusual circumstance, in that you would follow the procedure, and if it was a person appearing in your lab, um, you would follow the procedure, and the film would end up with your consultant offsite. But that's you know that's that's not how it works with the NEQAS film. Like Barbara said, you don't have the time, and so it wouldn't happen. It's of no risk to patients, because you would have followed the normal procedure. Maybe in your diagnosis in future, if you are concerned about that, you could put in your diagnosis and then say, would refer to consultant for final
Mm,
diagnosis. Just if you feel like that is the way it would go, and then you could send the film off-site for their analysis, but that may not come back in time. So you could, if once that does come back, you could include it in the report to say you got the same as the consultant, or the consultant felt it was this. So you could use it within your timeframes, even though that doesn't work with NEQAS's specific timeframes.
yeah.
I think that would be my advice.
Yeah, no, thank you for that. And I do appreciate the challenges of this. And I will say that we don't actually mark diagnoses or
Yeah.
suggested diagnosis. It's only ever suggested because you wouldn't make a diagnosis just on that. It is just a little bit of interest, really, to ask people what they think might be the basic cause. We don't mark that, and we've got no plans to mark that. This is morphology skills, and we do appreciate that they're going out to people with a wide range of backgrounds, wide range of skills, and wide range of experience, and that it is almost impossible to mark those.